Assalamu alaikum. I am Dr. Asmatullah from Peshawar. Today our topic of discussion is laceration. This is our second lecture. The presence of eyelid laceration, however insignificant, mandates careful exploration of the wound and examination of the globe and adnexal structure. So, any eyelid defect should be repaired by direct closure whenever possible, even under tension, since this affords the best functional and cosmetic results. We will see the figures. Okay, if the laceration is superficial, laceration parallel to the lid margin without gaping can be sutured with 60 black silk or nylon. The sutures are removed after 5 to 6 days. If we keep the suture more than that, it will cause infection. Okay, if there is infection is always a risk even from a small laceration, because the eyelid structures are soft tissues and there is always chance of bacteria and causing infection. If the lid margin is involved, then what to do? Laceration invariably gap without careful closure, and to prevent notching must be sutured with optimal alignment. Okay, now they had explained all the procedure of that how to do it. Okay, 50 silk vertical mattress suture is inserted in line with the meibomian gland orifices, about 2 mm from the wound edges and 2 mm deep, and left untied. Tarsal plate edges are brought together with partial thickness lamellar 50 absorbable polyglutane sutures which are tied interiorly. The lid margin silk suture is then tied so that the cut edges slightly pucker the wound. The ends are left fairly long, about 2 cm. The overlying skin is closed with interrupted 60 or 70 nylon or absorbable sutures, securing the ends of the silk suture to the direct these and it's not away from the cornea. We will see the diagram now. 22.3. Okay, come here. This is a case of laceration involving full thickness laceration of the lid margin. They had closed it, direct closure. Okay, now look at this one. If there is a tissue loss, we have to prevent notching, as well as we have to prevent shortening of the lid. Now, how did it occur? He started from here, coming, entering at the gray line into here, and then coming here, coming out of the gray line over here. Okay, and then entering into the gray line, coming out inferior to that, and then over here to the gray line, then tie it. Then you can apply other sutures. Now look at this. The edges of the silk suture were long, so they are buried under the other sutures, so it will not cause any trouble to the patient. Initial approximation of the tarsal plate with an absorbable suture and lid margin with a silk suture. B. Completed repair and reconstructed surgery. Okay. Now If we have mild tissue loss and laceration, what to do then? Laceration with mild tissue loss, just sufficient to prevent direct primary closure, can usually be managed by performing a lateral cantholysis in order to increase lateral mobility. You will do lateral cantholysis, so it will be close, direct closure can be done. If we have laceration with extensive tissue loss, like more than one third, may require major reconstructive procedures similar to those used following resection of malignant tumors, which are explained in chapter number 2. Okay, now a special case when there is involvement of canaliculi, then what to do? Canalicular laceration should be repaired within 24 hours. This is important. Most of the time it comes in MCQs. A laceration is bridged by silicone tubing. We will show the diagram then, which is also called Crawford tube, which is threaded down the lacrimal system and tied in the nose, following which the laceration is sutured. Alternatively, repair of a single canalicus can be performed using a monocanalicular stent, which is mini Monaca stent, and if necessary, suturing its footplate to the lid using 8-0 material. The tubing is left inside for 3 to 6 months for healing. Okay, we will see the diagram 24.4b. Look over here. This is a case of canalicular involvement. This is the canaliculus and it's damaged. So what will we do? First of all, we will pass pigtail from the upper canaliculus through like this. Okay, and then over here. Then what we do, let me change it. The green is our canaliculus, our DCR tube. We will attach this DCR tube with pigtail, and then we will remove the pigtail backward. Okay, like this, and this happen, then we will attach this to one another. Let me show you. Okay, we will pass it like this, it will come out like this, and then we will attach it over here. After attachment, we can repair the rest of the lid, and then these two ends will be attached to the skin over here or over here or over here, wherever you are easy to do it. Okay, and this is a mini Monaca stent for the monocanalicular repair. Now another important thing, tetanus status. Tetanus status is very important. Ensure that the patient tetanus immunization is satisfactory after any injury. Without prior immunization, 250 units of human tetanus immunoglobulin are given intramuscularly. If previously immunized, then what to do? Then, then patient just need a booster dose of tetanus if it's not given since last 10 years. And what we use in it? Subcutaneous tetanus toxide. If there is any suspicion of foreign body in the soft tissues, a CT scan should be undertaken. What is the tip? There is always risk of arteritis after penetrating lid laceration, particularly if there is retained foreign body. So you should be very careful about it, and tomorrow we will discuss another topic then. Okay, take care.